Afternoon, everyone, and thank you all for being here. So there's always a danger after lunch that the numbers go down and everyone's post-lunch blues might set in or sleep, so please do stay with us as we go through a great session ahead, which is timely and needed reflections on how we will be embedding EDI in our research, education and healthcare. And I'm sure that you were all touched by Ronke's words early on that really spoke to us about the importance of lived experience. And as she was talking, and as I said to her later, managing to make me cry, which I had tried to avoid, just because, you know, we don't want mascara running down one's face. I did reflect actually with her that my cousin has sickle cell, and in the last 2 years, she's lived with me, and I've had to put her in a taxi on more than one occasion to send her to King's College for where she has her treatment. So for me, I was wondering, what am I doing up here chairing this session? And I realized that at least my lived experience of some of the really important issues that we are tackling here is something to bring to bear on what we're talking about. And we're reflecting in all areas of how can we make it business as usual to have EDI as part of the things that we do? So if culture is just the way that we do things repeatedly, how can we make that culture absolutely focus on equality, diversity, and inclusion, because it leads to benefits for our patients, as has been demonstrated in some of the talks that we've heard earlier today. So in this session, we have talks demonstrating impact in each of these areas. In equality, thinking about what equality means versus equity, and understanding some of the subtle differences in that, and how we can begin to embed that in some of the practices that we bring to our patients, to our research, and to our education. We're thinking about diversity, looking not only at diversity maybe in some of the ways that we're used to thinking of it in terms of race and gender, but actually thinking about diversity amongst those who do research, amongst those who carry out the research, and those who come from not only different backgrounds, but different professional backgrounds in that arena. And then we're thinking about inclusion. What does it effectively mean to include patients, to include the community in the research as we're taking it forward? Really important to do that. Nothing that is for us without us ideology, and really making sure that it's impactful in the ways that we're bringing those things forward. This morning, I had the privilege, and I say it's a privilege, of walking my 11-year-old to school, and she used it as an opportunity to try and get something out of me. You know, so teenager's going to be interesting. And she was trying to convince me that she needed to get a fitness watch or a Fitbit, and you know, I found a really cheap one, Mummy. It's only 40 quid, okay. And so in that context, we were talking about how it is important to make exercise part of your everyday rather than an add-on. And so I was saying, well, if I get you a Fitbit, you need to make sure that you walk to school with it on and use that as your day-to-day activity of fitness. And it did make me reflect on how some of the work that we do in EDI, we make it too much of an add-on. It's something that we turn to. We've done everything, and then we turn to it, and we want to bring it in, and it's too late, and we don't use it as part of the thing that we are doing every day. And so hopefully through some of these sessions, you'll get an opportunity to really reflect on some of the things you're doing, the projects you're working on, places that you're in, whether that's as a clinician in healthcare, whether that's as a researcher, whether that's part of the community. How can we incorporate the principles of EDI in what we are trying to achieve in the business as usual of what we're doing every day? Otherwise, we will not be able to achieve it. And so with that, I'm going to turn. I promised to give the speakers more time so that we could hear readily what we had to say. I'm going to first of all highlight that there are questions on the Slido, so we will try and get to a Q&A at the end. And I'm going to ask Professor Emily Williams, Vice Dean of People and Culture, Professor of Diversity, Development and Inclusion at King's College London, to open up the session for us.
Thank you very much. Yes, so I'm Emily. I'm a social epidemiologist, and my research largely focuses on ethnic inequalities in health and more recently in educational outcomes. But in my role as Vice Dean, as Rantimi pointed out, I have responsibility for our developing and delivering our EDI strategy for our staff and our students. So All of that means that I'm really passionate about how we address health inequalities, and I'm going to do hopefully a short overview today of the ways that I think we can achieve that most effectively. So the way I think we can do this is through three main routes. The first is through our research, and we've heard quite a lot about that today. The second is through our education of our healthcare professionals, and the third is through our operations and our behaviour and treatment of staff. So touching just briefly on each of those areas. So as we heard in the earlier session there, we obviously really do need research that focuses on health inequalities as the topic. But what we're going to talk, I think, about a bit today is also how we do that research. And wanting this inclusive practice to be much more business as usual, as Rantimi pointed out, and to ensure that we engage and enable participation from a diverse range of research participants. So that means we have to focus really hard on our research design. I don't want to labour this too much because it does feel like this room is quite on board with how we do that. It's about how we recruit our research participants, moving beyond the sort of usual suspects of people who volunteer for research, and us as researchers being motivated to reach a broader range and a more heterogeneous participant sample. We also need to think about the data that we collect so that we collect the right data that means that we can explore health inequalities across groups. But it was touched on briefly by Seb, thinking about how we use those data really carefully. And we need to be thinking about how we analyse our data in a way that means that we don't oversimplify the findings. So when there's an unexplained finding, we don't assume it's attributable to group differences when it actually could easily be explained by other covariates. So this really has to be done with great care and a priori reasoning. In research, we're being encouraged all the time now to think a lot more about our social impact of our research beyond just the academic impact, and that's a really important change. But in that, we need to be thinking about how we connect with our diverse groups, and again, that's something that we're going to hear a lot more about shortly. So we're thinking about how we disseminate our research to be as acceptable, as clearly understandable to all of our patient groups and a really wide range of our population. And that was something that Julia pointed out, needing to make sure that our research is really well understood by the people, the population groups that need to understand it. So we've heard really fantastic and exemplar examples of inclusive practice today, and particularly in the engagement of PPIE, and so patient and public involvement and engagement. So again, I'm not going to labour this, but just about the importance, as we've heard from people with lived experience today, of listening, really listening to the experience of the people who have the conditions that we're looking to understand better. And this is an expectation in our clinical and our health research, much more so than any other discipline. But really meaningful and equal partnership with those community and patient groups is still relatively rare. So Dr. Fontaine-Palmer is going to be helping us rethink those partnerships later on. And if we expect our researchers to be fantastic at inclusive research design, then we need to think better about how we train them, because that's not something that we do as standard. And funders are now, like the MLC, are expecting universities to be teaching researchers about inclusive practice, and that's meant to be embedded in all MLC applications. So these levers that funders are using is a really positive move to be driving researchers and everybody to be thinking about how they embed EDI, and their research has the greatest impact for a wider range of our population. So I want to just talk really briefly about a study that I'm a co-I on and is led by Professor Katrina Whitaker at Surrey. It's called the Interpret X study, funded by the NIHR, and it's the UK's first evaluation of interpreting services within primary care in the UK. So it's a programme that is intended to address health inequalities for groups who require language support when they need to go and see their GP. So just to bring out the particularly novel components, the unique part about this grant is that we developed it in partnership with a research an external research company. But that partnership has meant that they collected all of our data for us, but it has meant that they provided multilingual researchers, live translation of our questionnaires in the language of choice for the participants. They were embedded in the communities that we were looking to understand. Their use of snowballing techniques meant that we reached a far greater number of people with really limited English than we would otherwise have done with our traditional recruitment methods, and also based on the funding envelope that we had. So this was a really successful partnership, but one that was unusual for us as researchers. Now, PPIE was also very well embedded in that. We had a paid PPIE investigator on our research project, a paid PPIE group who developed the research with us from start to finish. And one of the 3 work packages of Interpretex is a dissemination stream, which is looking at how we communicate our findings in the most relevant way to underserved communities who are going to need the research findings most. Now, this isn't a perfect example of inclusive practice, but it's just to suggest that when we start to do things a little bit differently, it means that we can connect with these patient populations that we often unfairly label as hard to reach. So we can also address healthcare inequalities through our healthcare research, education. And we have really fantastic educators across our healthcare programs in the UK. And it's really essential that the content keeps pace with our growing understanding of health inequalities, our greater understanding of structural inequalities in society and within healthcare, and the diversity of our patient groups. Now, the medicine and healthcare education that we teach needs to be representative, of course, of our UK communities, and that it emphasises the skills needed by clinicians to deliver values-based medicine, so skills like cultural humility and reflective practice. A really nice example of how MBBS within King's is working with the current staff to try to upskill them is a reverse mentoring program, which is led by Sam Thenabadu, Rini Paul, and Yvonne Batson-Wright, and in partnership with our student African Caribbean Medical Society. So the Black medical students mentor senior members of staff within the faculty and help us understand the impact of race equity for their lives in their role, in their positions as students in placement, and to be sort of challenging us as staff to be doing better with our cultural safety within the programme. Like inclusive research practices, inclusive education is also getting a lot more emphasis and a real push at the university. So it's got a renewed focus within Folsom, the Faculty of Life Sciences and Medicine, and we have new inclusive education leads in Dr. Fleur Cantle and Dr. Mandeep Gill-Sagu. So this is an area that we're really trying to develop and hoping to be leaders within King's. It is a very brief snapshot of an inclusive and race equity project that I developed when I was working at the University of Surrey. It's funded by Frimley Trust and NHS England, and it's what I delivered was a feasibility and acceptability trial for nursing students for an inclusive education and inclusive leadership program. And the aim is really about trying to address the lack of career progression for racially minoritized nurses, but the program was for all nurses. So what we can see here is it's a multi-component program for components 1 and 2, which were embedded within the program. These were really easy to deliver, so they were more the business as usual. And the other components were included as add-ons for those nurses who consented to be part of the program. But overall, the program was about improving the understanding of race equity for all students, all nursing students and staff. It was about developing allyship skills and improving representation, particularly for racially minoritized students who didn't see themselves reflected in the staff population. But then also really working with staff to upskill teaching staff and clinical leaders to be able to start recognizing where racism and discrimination fits within in their workplace, and then challenging and working to overcome that. So overall, the project was very successful. We got great feedback from the students about how they would be applying it in their future nursing careers. We saw an increase in empowerment for the racially minoritized students, increases in a sense of belonging, and increased self-efficacy. So just a sort of to link to Rantimi's point, this was a difficult program to implement because it was trying to include it in an already very busy curriculum for the nurses. So the embedded components worked really well, but it was not without challenge. So what we did was we developed an organisational guidance document for any other programme that was interested in introducing this type of anti-racism programme into a healthcare curriculum. So that we were able to give feedback and recommendations for implementation. But these are the types of extra work that does need to be done at the moment to get anti-racism and EDI into our work until we get to the fantastic point where it is our business as usual. And then finally, just to talk about how we can address inequalities through how we behave and our operations within our organisations. And hopefully much of what I'll be talking about, just very briefly, is already in place within the partners of KHP. But this is, I won't be able to talk about how we can embed EDI throughout our operations, but it is all the inclusive recruitment so that we've got fair recruitment and promotion processes. And it's about things like having really robust and challenging anti-bullying policies and reporting tools. It's also about how we support and develop our staff. And with an EDI lens, that's about how we have programs potentially for our underrepresented groups. Now, that isn't about a deficit model, but it's about programs that recognise the structural disadvantage that we still have in many of our systems and the need for safe spaces for some of our staff and programs that really support that. Within King's, we have we're lucky enough to have one of the Wellcome-funded research culture programs, and ours is called Include, and it's led by Professor Stephanie Hatch and Professor Tim Newton. And that's a really fantastic program focused on addressing underrepresentation and additional support for underrepresented researchers within our community. Now, one of the things that's novel about that is it places an emphasis, it's not just looking at the researchers, but looking at the research infrastructure and placing an emphasis on line managers to become much better at supporting their diverse teams. And that's not something that we've seen line managers necessarily have to be very accountable for, particularly in research groups in the university, but something that we need to do better on to be addressing toxic research culture, which disproportionately affects racially minoritized staff and women. So, hopefully I've given you a taste of how I think we can be addressing ethnic inequalities in healthcare through our research, through our education, and through our operations and behaviour. And I think all of these pathways can lead to improved care for patients and reduced health inequalities. But also in a workforce as diverse as the NHS, it can lead to improved NHS workforce retention, particularly for racially minoritized staff, which we know is a key issue. So we've talked a little bit about this. This isn't yet business as usual. This work does take a little bit more effort, it takes a bit more time, and it often requires a little bit more funding. So we need to be thinking about how we all engage. And I really like the way Julia described it as shared work for everyone. This can't just be the invested few who help drive forward EDI progression. We need everybody to be involved. Thanks very much.
Thank you very much, Emily. That's really appreciated and really on point. I'm going to now ask Dr. Daniel Hadfield to step up. He is a critical care nurse researcher at King's College Hospital and an honorary lecturer at King's College London. Thank you very much, Daniel.
Thank you very much. Thanks for inviting me to talk. Can I be a pain and ask for a glass of water before we start, just so you don't see me dry up and stop? Would be best. Thank you so much. Right. Thank you. So, I suppose the question is, who am I? And what do I do? Why am I here? I don't want to worry the organisers with that start, but I am a critical care nurse, but I'm also a healthcare researcher. And I've been doing that, or I've been in research for 14, 15 years at King's College Hospital. But being those two things is still very unusual. despite the fact that we know that we need a diverse research workforce, we need diverse researchers. And it's been firmly on the NHS agenda for more than 20 years, yet I'm still in this unusual position. So that's the main point. And I will come on to talk a little bit more about me on the next slide. Don't make myself self-conscious. I'm using myself as a case study to show some of the issues on the pathway. I usually talk about non-medics getting into research. I do a lot of advocacy for non-medics getting into research, and that's what I really enjoy. This topic, or rather the title was provided to me, which is great, and I was very interested. I went down a little bit of a rabbit hole at the start, which I'll just walk you through a little bit. So it raised a lot of questions. What is an academic? And there's various answers to that question, depending on where you look. Is it someone who works in a university, someone who's qualified with a PhD, etc.? And likewise, what is a researcher? Can anyone do research? Can I do research in the hospital in particular without a university? The next two questions keep coming up. They came up when I first started this in 2010, when I started getting interested in clinical academic careers. And this week, in a national meeting of CARIM, which is the Clinical Academic Roles Implementation Network, we spent 20 minutes discussing the same thing. And that is, what is a clinical academic? What defines being a clinical academic? Do we have to be a certain proportion clinical? What does that look like? And what does the academic side look like? Get the point of this is that we need to move on a little bit from these conversations. I went further down that rabbit hole, and there were some less useful things that I found. A definition of academic, but I suppose that's the point of a health science centre, is to bring the theoretical together with the practical to drive research. But I found some useful things, and I particularly liked this, and it was from Brighton University. The research offers a diverse, rewarding, and inspiring career. It welcomes people from all walks of life. There's no type, background, or innate talent. And I particularly like that, because I had no idea when I started this that I could be a researcher or that I wanted to be an academic. It's something that I found that I was good at. I was supported, mentored, supervised by the right people. And that's how my pathway started. But I think there's some preconceived ideas that put blocks in our way from many avenues, really. And that comes from more, do nurses do research? Is it just the medics that do research? You haven't got an academic background. Can you do a PhD? These kind of things. So I think we've already answered the question. So I'll just say that at the start. We know research is not just for academics, whether you define them as being in a university or just with a PhD. Research is not just for any group. Research is always better when you're doing it with a group that reflects the people, the patients that you are treating, and the staff that are in the NHS. So in this presentation, I want to talk about my journey as a case study, because there are very common issues that I know are shared between clinical academics in my position, people who have gone through the training process and are coming out the other side. So, as I said, I started my clinical training in 2004 and became a clinical specialist in the ICU, but moved across into a research role, and that was a research nurse. So that's another thing to clarify. I'm not a research nurse. I have been a research nurse, and that was very useful as training and an introduction into research. But I was very, very fortunate to meet Phil Hopkins, who's a doctor in the ICU at King's College Hospital, who was totally open and totally encouraging and positive, and remains so to this day, about the need for me to find my own topic and just to see whether I wanted to do the research myself. Likewise, I've been supported by Christine Norton at KCL and by Jed Rafferty, who's an academic physiologist at the university. So I did develop my own subject fairly early on. It was a steep learning curve, and it took a long time to get there because I genuinely had a long way to go. but I started putting applications in. And what this slide doesn't show are the number of failed applications. That took a long time, but I got there in the end. And I suppose it's a bit of a KHP success story because I've been through a Guy's and St Thomas's BRC fellowship and moved on to the NIHR doctoral fellowship. After the doctoral fellowship is when some of the problems came, because that was an introduction back into the NHS, and finding my role and finding my place there wasn't so easy. But I got continued funding from the NIHR to support new pre-doctoral researchers, people who are entering the system, which is what I really enjoy doing. And I got some other funding to continue to develop my work, the work that I did in the PhD, which was focused on mechanical ventilation towards a larger study. And that's a very long process. And there's a lot of time on applications, a lot of time within there, actually spent on COVID, to be honest, at the bedside as well. But the result, quite recently, in the last few years, is a very successful grant application. I've now extended my PhD work to a national study, and we are in setup at the moment. The grant has started. It's going to be in 40 hospitals across the NHS. So I'm now a chief investigator of a national study, and I'm also in a very privileged and fortunate position to be given time to do research, to develop other projects, which I'm trying to keep running along at the same time. Apologies for the size of the text. I was imagining a bigger screen. But so if I read some of them out for the people, I'm looking at prone positioning in non-COVID patients, music therapy, breathlessness in the ICU, deteriorating patients, critical care outreach, etc. So I'm very lucky, I'm very fortunate, and I really do love what I do. And I'm proud of what I achieved. So you might say that was the aim. It was the aim of the NIHR with their first fellowships in 2009, going further back to best research, best health. We know that we wanted people like me in the NHS. So, and this is not a comment on this institution because this is happening everywhere. In that time, well, now, at the moment, I don't have an official role still. I still can't find that place, that definition within the institution, and my pay grade has remained the same for 14 years. So I don't want that to be a direct challenging point to this institution, because it is the same. The issues are the same across the country. And we have made a lot of progress. Apologies. So again, sorry about the text, but there's definitely an increased focus on within strategy, within professional bodies such as the NMC and the CQC. There's much more national leadership and groups and initiatives, many more training schemes and opportunities to build that capacity of people who are trained in research. There's definitely some progress in institutions. We do very well here at KHP and Guy's and St Thomas's with the Clinical Academic Training Office, with the different working groups that are starting up at KHP, with ACORN at GSTT, etc. And we are leading the way in terms of fellowship applications with our institution. I think there are still areas for improvement. We need more support from within the NHS. We need to join the message that's coming centrally, that we want academics, with what is actually happening within the institution with people like me. And a big thing that I think we need is more collaboration between experienced researchers from different professions, we need their input into the training, into the support, the mentorship, the supervision of others. We need to make more diverse research groups, and we need that to be obligatory, really, on research groups to do that, because there's a lot of experience to share and training to do between these professions. A quick snapshot, a positive snapshot of some data, if you can see this, but this is a one-year snapshot that I took, data I collected from the non-medic clinical academics at King's College Hospital, with a loose definition on clinical academics. But I hope you can see there that it's quite a diverse group in terms of professions. And I really wanted to highlight that in 1 year, there's a lot of output. There's a lot of journal publications, presentations. There's an awful lot of income as well from this group, despite the fact that I'm saying that really the positions aren't there for academics. It's a little bit pressured, I suppose, to get these things achieved. So my final thoughts on this to wrap up. I think I've confirmed we've had this conversation already. I don't think we need to keep discussing what is a clinical academic. We don't need to discuss the value of having non-medics in research in the NHS. That's confirmed. It's been said by the NHS for so long. We need to move on to implementation. We need to make it happen. Anyone can be a researcher, but I think collaboration between the groups is definitely key. Different groups have got a responsibility to include and train and support and definitely give credit where credit is due for the work that's done for our research, which is maybe a separate issue for another presentation. I probably shouldn't have put that as the final point, but research is research. It's just challenging these preconceived ideas. I'm a nurse, I do research. I'm not a nursing researcher. I'm a healthcare researcher. I don't research nursing. We all have our specialisms. It just is important that we all support each other and try to move forward. And I am absolutely convinced and know that that will make this whole journey move faster and make the care that we give to our patients a lot better. Thank you very much.
Thank you very much, Daniel. I think there's some really important reflections on what it means to have a true multidisciplinary team within research and what that can bring to the speed at which we tackle some of the challenges that we have ahead in healthcare. So thank you very much for that. I'd like to move on to introduce Dr. Sabrina Bajwah. She's a clinical reader and honorary consultant in palliative care at King's College London. And she's going to be talking to us about some important work and projects that were brought about during the COVID period.
Thank you. I'm delighted to be here. So I'm a clinical academic, a clinical reader at KCL, but I'm also a palliative medicine consultant at both KCH and Guy's and St. Thomas's. So I'm here to present some research that we did during the COVID pandemic, looking at the palliative care response, and specifically I'm going to be talking about our response to meeting the needs of ethnically diverse patients. Whilst this research is focused on end-of-life care, the learnings and recommendations we make are applicable for everybody working across any healthcare speciality. So what did we do in the CovPal research, and specifically this bit? We aimed to map and develop insights into the response of palliative care for patients and families from ethnically diverse groups during the first wave of the pandemic. And we did this through cross-sectional online surveys, and which we sent out to palliative care services, and we measured quantitative and qualitative data. So the questionnaire asked, have you encountered patients or families with COVID-19 who are from Black and minority ethnic groups, yes or no? And are there any differences in how you were supporting them or reaching them? And are there any groups, different religions or cultures, where you have found supporting the individual needs of people affected by COVID particularly challenging? So what did our results show? We had a response from 277 palliative care services across the UK, and of those, 93 services had specifically looked after ethnically diverse patients. About half of those services were based in hospital, and ethnically diverse patients were much more likely to have been looked up after in hospital at the end of life. So the qualitative themes were really interesting. So the data showed that services reported that there was a disproportionate adverse impact of restricted visiting. and that there were compounded challenges related to communication from restricted visiting, marked distress related to unmet religious and faith needs, and a mistrust of services that had already been there was really compounded by the COVID pandemic. What, for me, the most interesting thing about this data was that repeatedly services talked about how they had delivered equal and personalised care. In fact, about 2/3 of services indicated that they had focused on equal care rather than adapting a different approach to care to meet the needs of these patients. Oh, I think I've lost one. So within our paper, we talk about how actually this focus on equal care and delivering equal delivery of care and equal allocation of resources is appropriate for those people who are the served group, so the white British group. But actually, a focus on equal care and equality in general leaves an inability to respond to individual cultural and religious needs and actually causes distress. And this is an example of structural racism. And what this does, this equal response, will lead to unequal outcomes. So within our paper, we talk specifically about actually, rather than treating everybody equally, what we need to do is treat everybody equitably. We need to adjust the care, the models of care, and everything that we do to meet the needs of patients and give patients what they need. And really, this includes not focusing on equal access, but equitable access, thinking about the information we provide about services, thinking about how we deliver those services, and thinking about the needs of these populations. And when we deliver equitable care, thinking about whether we are actually doing it in a way to meet the needs of these patients in terms of translation, health literacy, and really delivering the care in the community as needed. Fundamental to building trust with these communities is thinking about delivering culturally and religiously congruent care. Only through doing that and really informing our workforce on how to do that can we build trust. I can't tell you the amount of times as a palliative care consultant that I come into a situation at the end of life and the other health professionals around me don't understand what the cultural and religious needs of that patient and that family are at the end of life and how much conflict that causes. And fundamentally, we need to think about redistributing our resources. If there are groups of patients which need more resources to achieve the same outcomes, then that's what we need to do. We need to redistribute our resources. And data is powerful, and we don't know what we don't know. So fundamentally, if we're not breaking down all our outcomes by ethnicity, we don't know whether we're delivering equitable care. And I would like to urge you that going forward, that if you're developing a service, if you're developing an intervention, actually don't develop that based on the white British model of care. I'd like to see more people focus on the margins, thinking first of all, what do the underserved communities need, and placing your focus of development of care for them. So I'm delighted that the published article has been downloaded 20,000 times and has had really great traction with 4 media outlets picking it up. And also I'm delighted that both the UK government and the World Health Organization have cited this research as demonstration of racial inequity at the end of life. However, wanting to actually change practice on the ground, I applied for a research into clinical practice grant. What this enabled me to do was to go up and down the country, interviewing stakeholders, and really using these stakeholders' voices to describe the importance of meeting the needs of ethnically diverse communities. Within this 26-minute film that we've produced, we explain the difference between equality and equity and why we should all be aiming for equity. In addition, we give individuals and organisations tangible ways that they can change the delivery of care to ensure equitable care going forward. So this film was launched on YouTube last year, and I'm delighted to say that it has garnered almost 5,000 views to date. So please do watch it. So in conclusion, I would like to say that treating underserved groups equally can lead to equity and distress. So please ensure that you do focus on equity rather than equality. And actually, the focus shouldn't be on equal access. It should mean the focus should be on equal outcomes. So as I said, data is incredibly powerful, and fundamental to that is measuring outcomes. And what we need to get better at is recording data, ethnicity, accurately, so that when we do measure outcomes, we do that both at baseline, broken down at ethnicity, and then when we deliver interventions or changes in services, we can accurately see whether those changes improve inequality or inadvertently increase inequality. So racial inequality is everywhere. It's deeply embedded within our society. And I was delighted to hear Graham mention this morning that there is structured racism in healthcare. And I think that's something that we should open our eyes to, and we should label this inequality in the services that we deliver as structural racism. Only then can I see that we will fundamentally change urgently the care that we deliver. And Graham asked this morning about those strands, which the golden strands, which should go across everything. And I think equity is one of those golden strands that should be across our mission, our vision, and our strategy. And only then can I see that we're going to change outcomes for those to date who have received the best and most, and reduce that inequality for those who continue to receive the least and worst. Thank you.
Thank you very much, Sabrina. You've spoken really powerfully to making equity the golden thread through all that we do, and all of these talk to bringing that through research, bringing it into the healthcare that we provide, so that we're making sure that there's equity of outcomes. And I think that it's something that we're all moving towards, and something that we are trying to ensure is happening in our healthcare. And you've given a powerful representation of how that can be done, and the advocacy work that you've then developed beyond that. So thank you very much. I'm going to thank our three speakers here. They're going to come off the stage at the moment while we move to a video. This video is being presented to us by Naomi Limbachiya. She's an EDI research coordinator in the Department of Neuroscience at King's College London. She's going to talk to a model of research recruitment that has enabled us to increase the number of participants in research that have come from ethnically diverse backgrounds. She's unable to be with us today, so we're going to have her video presentation.
Good afternoon, everyone. My name is Naomi, and I'm the EDI Research Coordinator working at King's College Hospital. I am very sorry that I won't be able to be there to present this today in person. And it's because one of our research projects actually got accepted into the International Movement Disorders Conference in Philadelphia. But I'm very pleased to be able to present some of our work virtually. So today I'm going to be explaining how we can diversify recruitment and research and the importance of this and how this is really fundamental to the King's model, which is a framework for increasing the diversity of clinical trial cohorts, which my colleagues developed. So, something that the COVID-19 pandemic really highlighted is that there are inequalities all around us, particularly pertaining to the healthcare system and patient treatment. And two examples of this are the reports that levodopa, which is the mainstay treatment for Parkinson's disease, is not available to some regions of the world. So, particularly in India, where there's a private healthcare system and a very large population, levodopa isn't always available to everyone who's suffering with Parkinson's disease. And as you can imagine, this creates great disparities in the treatment of these patients. Another example, which is more relevant to the UK, are ethnic disparities in the treatment of those with chronic pain who have Parkinson's disease. So, chronic pain and pain in general is one of the most common non motor symptoms in Parkinson's disease. And what this study, completed by my colleagues, found was that despite those who are Black, Asian, and Caucasian living with PD all experiencing a similar pain burden, it was the Caucasian individuals with PD who are more likely to receive pain medication compared to Asian and Black individuals with Parkinson's disease. So these are just two of many examples of inequalities in racial healthcare inequalities that continue to exist and contribute to significant suffering and healthcare disparities. And this really forms the foundation of the King's model. So, the King's model is a set of local and community interventions that aims to increase the diversity of clinical trial cohorts. And the purpose of this is that clinical trials really bridge the gap between research and clinical interventions. And they still remain the gold standard for evaluating novel therapeutics. And so, if we have these clinical trial cohorts which have an overrepresentation of Caucasian individuals, we are only getting half the picture of the effect of these medications. And this is particularly highlighted over recent years because of the advancements in genetic sequencing methods, which have shown that there are ethnic differences in concern to the prevalence of certain genetic variants. And so, if we are neglecting, along with the general response to medication because of things like specific comorbidities, and so if we're neglecting to include these individuals, then we won't be able to generalize the results that we're getting from these trials to these different ethnic groups. And so the King's model involves these local interventions which aim to include all those who are involved in patient care settings to discuss these disparities, these racial disparities in research, and to really provide them with the resources to try and overcome this and increase the involvement of ethnic groups in research. And it also involves these community outreach methods that are aiming to increase awareness of research in the general population by liaising with local champions and creating webinars that really address some of the concerns that these groups might be having, so that we're able to understand further about the barriers, but also so that we're able to ensure that we're giving them the correct information about clinical trial research and research in general. And as part of the King's model, we have also developed the MAID scheme to ensure that the King's model is effectively implemented across the units that are using this framework. And this aims to monitor the ethnicities of participants in research, but it also aims to ensure that there's a trust-wide initiative that is encouraging the recruitment of ethnic minority groups and ensuring that these individuals who participate are given equal access to research and they have a good and safe experience in the process. And upon implementation, we found that there was an increase in commercial and non-commercial studies. So in commercial studies, there was an increase from 6.4% to 16.1%, and in non-commercial studies, there was an increase from 30% to 41% and 59.2%. So this seems to be an effective framework for different types of commercial trials. So now we're aiming to implement this across the whole of King's College Hospital. And in order to do that, we understand that each research delivery unit has a different way of recruiting participants, different objectives, and different criteria because they're looking at different diseases, different conditions. And so as part of this clinical audit, we're trying to quantify the protected characteristics of recruits. But also we're looking into how this information is monitored, what protected characteristics are being monitored and how, because we can't do this research if we don't have this data that's made available. And we need it to get the most accurate picture of ethnic minority recruitment across the whole of King's. Additionally, we understand that numbers only tell us half of the picture. And so we've created this survey in order to understand the views, challenges, and current interventions that are being used to increase the diversity of clinical trial cohorts. And specifically, we're looking at whether any of the King's model criteria are being implemented across research delivery units, and if so, how, and for how long, and how this matches up with the clinical audit that we've done, so that we can understand who might benefit from the King's model framework and in what way. And just looking at one part of the survey data that we've collated, we found that language and cultural considerations are one of the most prevalent barriers reported across the RDUs in terms of recruiting these ethnic minority groups. And we're currently trying to address this by creating patient-facing documents that are able to be translated in different languages. Along with this, we're also looking at the diversity of external trials. So we're running 2 projects at the moment. One is looking at the diversity of clinical trials investigating the most prevalent neurological conditions from 2014 to 2024. And we're in the process of analysing and writing up our results. And ideally, this will give us a worldwide depiction of diversity of clinical trials across these prevalent neurological conditions. At the same time, we're also looking at diversity of trials investigating COMT inhibitors. And with the chronic use of levodopa, one of the consequences is that patients will experience motor fluctuations, motor and non-motor complications that can occur because levodopa is becoming less effective. And so COMT inhibitors are a drug that is prescribed alongside levodopa, that it essentially increases the availability of levodopa to the brain and in turn tries to alleviate these motor non-motor fluctuations that occur, which are known as wearing off periods. And so by doing this, we're hoping that we can really address some of the racial healthcare inequalities and disparities and understand how and in what way the King's model can address these on a worldwide scale. I'm now going to show you a video from one of our participants, Omotola, who very kindly explains the impact of our research work.
This project has the potential to impact not just Black people living with Parkinson's in the UK, but across the world. As a person living with Parkinson's that is from an ethnic minority group, this project matters to me because it would shed more light on the importance of focused, individualized care for Black people with Parkinson's.
I just want to say a big thank you for listening to this presentation. And if you have any questions, please do get in touch with me. Or if you have any ideas for some collaboration, then we'd be very excited and eager to hear of any ideas you have. And I hope you enjoy the rest of the conference.
So Naomi's not here, and so she won't get to be personally here to hear me embarrass her and say how amazing she is. I work directly with Naomi. And that model is one that we're hoping to see many more areas within King's College and beyond take up in terms of their ability to increase the diversity of participants within research. And now I'm going to ask our next speaker to stand up to the lectern. I'm introducing Dr. Saima Ajaz. I don't know how many of you have read the 163-page review from Darzi. Actually read it word for word. I'll test you all later. But some of the key aspects of it, some of what he discusses in there is around prevention. And our speaker here, Saima, is a specialty doctor in hepatology and lifestyle medicine physician at King's College and an honorary senior clinical lecturer at King's College London. And she's going to bring us timely reflections on some of her work that really speaks to prevention and moving some of the healthcare debate upstream.
Good afternoon, everyone. And it's really an honor to be presenting at this forum. And before we dive into the question that are we pushing the boundaries and are we innovating the healthcare system, I would like to say if there is an institute which is capable of making these changes, it's King's. This is because of the remarkable people that we have here. And this is based on personal appearance. And I would like to first start with the acknowledgement. This slide usually comes at the end, but I think it made more sense because my journey did not start at King's as a student or as staff, though I have been both, but as a patient. 20 years back, as a young medical graduate, in the last trimester of my pregnancy, I was told that nothing could be done. And I started to look for answers and to find people who can help me. And that brought me to Professor Kypris Nikloidis, who I think you all know, and from the Fetal Medical Center. I traveled across as an overseas patient, and I was under his care. What really moved me was not only his clinical excellence, his research endeavors, but his compassion and humanity. He has touched the lives of so many women, and I think how he deals with the patient is something that we need to learn from. And because of him, I was able to hold my daughter and see her smile, though she died. But I think at that moment, I wanted, and I decided that I will come to King's and I will work here with pioneers in this field. So again, King's gave me a chance. I was awarded King's Overseas Research Scholarship, and I was able to work with my incredible supervisors, Dr. Afsha Malik, who taught me a lot about research, and Professor Luigi Nudi, who has been a pillar of strength throughout my career. My first clinical job was also at King's at the prestigious Institute of Liver Studies, and Dr. Agarwal has supported me and encouraged me in all fields from research, advocacy, clinical practice, in everything. So I'm really grateful to the community of King's. And then we will start with the main topic of our presentation, that are we doing enough to change and challenge the healthcare system? I think there are a lot of problems, but with an unwavering belief that we can make it happen And as Desmond Tutu has very rightly reflected, that there comes a point when we need to stop just pulling people out of the river. We need to go upstream and find out why they're falling in. And I think we all know the problem. I don't have to highlight it. For years, our system has been reactive instead of preventive. And Lord Darcy's report couldn't have come at a better time. I think all of you have read this report, and it highlights all the issues that I think I wanted to put it in my presentation, and it just summarized it, that the system is in trouble. The health of the nation has deteriorated. Patient satisfaction is at its lowest. Too many staff are disengaged. And the patient voice is not loud enough. We don't hear people. And this is not a surprise. We know the healthy life expectancy is on the decline. So what are we missing? We do need to re-empower patients, re-engage staff. To work as a team is to work in a team. So we need multidisciplinary approach, and those models have to be implemented. It's very easy to talk about these models, but unless they are implemented, it doesn't make life any easier. And then we have to utilize the new models of integrative care and preventive lifestyles, such as lifestyle medicine. We do have amazing technology, and I think in the morning, the session showed that how many institutes there are at King's which can make a difference. We have to utilize them to develop these models. So are we really listening enough? Are we listening to the patients? And I would like to tell you a story about Sophie, and I know her personally. And she was a 20-year-old brilliant student trying to create an help which can improve healthcare. She developed headache, photophobia, vomiting, went to an A&E last year and was sent home, although her mother and she kept on insisting, could it be meningitis? And we rely more on the results that we have instead of listening to the patient. And her father, who actually teaches my daughter, he wanted to use this platform to say that anything you can do is that you should start listening to the patients and the relatives more. So the time is always right to do the right thing, and I think now is the time to involve patient in the healthcare. So I'm going to give you some examples in our model, how we have tried to implement it in the clinical practice. So my area of specialization is hepatology, and we know that it's one of the third leading cause of premature death in UK. However, 90% of the liver disease is preventable. We are facing a global epidemic of metabolic-associated steatotic liver disease, and all of you who are practicing, you would know that this is so common, and it is a multidisciplinary approach. When there is a bigger problem, first we have to justify that it's a local problem at all. It works locally. That's how the system works. That's how we deliver. And that's what we need to show for research and data as well. So we did a community project. This project is still ongoing. This is the pilot data. And it shows definitely that fatty liver disease is highly prevalent in high-risk individuals. However, the advanced liver fibrosis was 26%. This is unidentified patients without any liver disease. Average BMI of 32, and less than half of them consider themselves to be overweight. This means that we take obesity as normal variation. 69% of the patient had no idea about what fatty liver disease was. So definitely in high-risk population, there's lack of awareness as well. But when we educated them and told them, 99% of them wanted more information about the management and prevention. So again, we have to show that it affects the health system. It is cost-effective to screen these patients. So we went on the other side from the tertiary angle, and we tried to find out, is it affecting the cost is there a burden on the healthcare system? So this is the hepatocellular carcinoma MDM data from the last 6 years, and we found out MESL was definitely the most leading cause for HCC and with the lowest 5-year survival rate. We also used the technology, we used CogStack, and we found out that highly significant correlation of liver fibrosis exists with the ethnicity, and this is 25,000 patients who have been referred just for the FibroScan. Prevalence was also high in socially deprived area. So now we knew that there was a problem, but the issue that we had is there's lack of funding for a multidisciplinary team. There's no therapeutic options for this disease, so we have to depend on preventive and guiding lifestyle changes. There's limitations to integrate lifestyle into the actual practice. This can be because of the time constraint, how the clinics are set up. It's not easy to deliver preventive lifestyle in the clinics. So we knew how to address the problem. We knew that if there's early diagnosis and timely referrals, there's a high-risk population will have better outcomes. Increasing awareness and empowering patients, and then integrating lifestyle medicine into the clinical delivery. So we tried to find an innovative approach, and I'm very grateful again to the department who let me do this. We changed the format of the clinic. So in the NASH clinic, which the new terminology is MASH, but I will call it as a Live NASH clinic, we changed the format and we integrated lifestyle medicine in the clinic. What we saw in the 3 years audit was that the patients were losing, and 85 to 95% of patients were losing 5% of the body weight on every visit, which is recommended by the guidelines. And the clinical parameters was also significantly improved. Then we asked the patients, did they want anything else? So we did an online survey, and all our patients said they needed more advice. As it was not possible to give more advice because of the time constraint and the overbooking, we started the first patient support group for MASL patient at King's in 2019. And we have been running meetings every 2 to 3 months, guiding them about lifestyle medicine, nutrition, exercise, sleep. And I will just like to highlight, we did all this without any funding. What it resulted into was educated patient support group, which has been NIHR research champions, PPI executives. They have presented at international forums and conferences, and now they have started the first advocacy academy with collaboration with the Global Liver Institute. And this is one of our patients from the LiveFit. And this was last week where she became an advanced patient advocate for liver disease. And she's coming back and trying to raise more awareness with the rest of the community. So, does this approach had benefits? I think there were a lot of benefits. I'm just going to highlight a few, which is for the patients, it improved their health. They became more aware, and there was an engagement as well as advocacy. They were able to have more preventive strategies, which they could actually lead instead of the system providing it. They could actually lead in the community. Healthcare system benefit, because it always comes to the point that was it beneficial to the healthcare system? So with this, we were able to contribute to the clinical trials, and we have been driving innovation and patient-centered outcomes because of our PPI executives, which have been giving a lot of advice on setting up of the studies. We were able to sustain and develop a network of patient advocates, and definitely it brought a lot of financial benefits to the trust as well, and this is just one of the figures, which is from just fatty liver or MASL trials. So in the conclusion, I would like to say that definitely we can challenge the system, and there are ways to do it, but what we need to do is we have to involve patients in the delivery for a better healthcare. We need to encourage action, we need to motivate, we need to support our colleagues who are thinking out of the box and delivering something. And I think in the system, there's lack of such incentives. Although you have an idea and you know it works, there's not a structured report or structured framework which helps you to achieve that. And that's what we are trying to develop at King's. We have to improve health by integrating the new approaches, which is like lifestyle medicine and the other preventive strategies, and collaborating for the future. We have to have technology along with the tradition. So we may not be there yet, but I think we have the ability to achieve the system, which can be much, and I hope the next report is much more encouraging than the present one. Thank you so much.
Thank you so much, Saima. Thank you very much. I think that we do know that some of the answers that we need in the NHS are already at work in the NHS. And so there's a lot of this that we need to think about how can we scale it up and how can we make some of those really good examples be available to others in other healthcare systems, in other parts of the healthcare system and in our own. And I would like to finally introduce Dr. Nadine Fontaine-Palmer, who is CEO of Mabadiliko CIC. She's going to tell you a little bit more about what it's about. And she's going to speak to how we can get the community involved in research. And that's such a critical point. And I think is a really good session for us to be finishing this whole practical approaches to EDI on. Thank you.
Thank you so much. No pressure, the last main speaker for the day. Hope I can entertain you. So Mabadiliko CIC, we're a community-based organisation, and we have been working with King's Health Partners and its constituent partners for many years in projects around health equity, versus inequality, but very much with an anti-racism and social justice lens. And I'll talk to you today about a programme that we've been delivering called the Research Engagement Networks. It's an NHS England funded programme, and it's all about increasing diverse participation in research, so very much kind of on topic. We haven't been delivering this alone. We've been delivering it with what we call the Dream Team, informally, but more formally, it's a collaboration between Mabadiliko CIC, King's Health Partners, South East London ICB, and from the NIHR, the ARC and CRN teams. So in phase one, if I can move forward, and that funding was from 22 to 2023, we were pretty good and diligent at staying with the exam question, which was about increasing participation in research. And as part of what we did, and I'm going to give you a quick snapshot from that phase. I want to focus more on what we've done in the more recent phases. But one of the exercises we did in phase one was to speak to racially minoritized and marginalized communities across South East London to understand their barriers to getting involved in research. And surprise, surprise, and I think has been spoken about a lot today, the key theme was that around trust. And again, I think it's been mentioned today, negative feelings about research conducted on us by others, what that might mean for exploitation or extraction from our communities in terms of knowledge. And I guess most relevant for my talk today, a request for better visibility of community-based organisations, VCSOs, in the research process. And I think particularly recognising that there are many, many organisations across South East London who are delivering health services or delivering research activities that do have the trust of the communities, and actually how do we bring that sector into this endeavour around participation. So in phase one, we developed and implemented a community-led model for increasing participation. And in this model, what I call the formal research or health and social care institutions would devolve power and trust to community organisations, either community research organisations like Mabadiliko CIC, but also to these kind of more grassroots service delivery organisations, and to give us the space to do some of that recruitment for participation. But actually, we went one step beyond that in phase one and said, actually, is there a role for us beyond just getting bums on seats? And actually, with some capacity building and some infrastructure support, what other activities could the community-based organisations deliver to help this overall research endeavour? So we did some training around qualitative research, data collection methods, and we had these community organisations delivering focus groups, collecting data that we supported with analysis and infrastructure. The idea being that the community sector can, with the right level of devolved power and trust, deliver back to the health system community-driven insights with groups that are often described as being hard to reach or that we would normally describe as being seldom heard. So that's the participation bit. There's lots of successes. If you're massively interested in that, there are some previous recordings of me at KHP talking about that. But what I want to focus on more today is actually that, I guess, implementing and evaluating this model raised other questions around how do the relationships work between these layers? And so we started to think, well, okay, there's participation, and people have spoken a lot today about why that matters. Then there's involvement, the kind of PPIE stuff. Okay, who's involving who? Do I want to be involved in? Does that quite sit right? Does that support this model? And then we started to talk more about partnership. What does equitable partnership look like if we're going to successfully engage community organisations in achieving the outcomes that we want through research? So, from participation to partnership. And in Mabadiliko, we're kind of working out what words we want to use to describe this. I can't say that we're quite there yet, but there's something about a fundamental transformation in the way that decisions are made throughout the health ecosystem. And there's something about a self-reflection within the system that focuses on power structures, hierarchies. A previous speaker spoke about who is a researcher, a clinical academic researcher. Similar question, who is a researcher? What is research? What is knowledge? Where is it housed? Where does it come from? And how is it prioritized? And how do we make space for all stakeholders that we discussed today to have an equitable seat at the table? So again, we're moving from involving me in what maybe you're doing to actually how do we take this end-to-end journey together? So in action, what might this look like? So I've been thinking about these different stakeholder groups. We've got research funders. What would equitable partnership look like as a behaviour, perhaps? It's moving from having predefined agendas about what health conditions matter, what needs to be researched and where that money flows, to taking more community-driven priorities as part of the agenda setting. If you're a research team or a researcher, or if you are research, it's moving away from engaging communities and or patients at specific points in the life cycle to involving communities and patients through the end-to-end research life cycle. If you are a health professional, I'm thinking people who are on the front line delivering services, maybe service designers, commissioners, policymakers. Similarly, it's about not just inviting people into the room at periodic points in a service improvement project, perhaps, but actually what does continuous co-design with communities look like? If you're a participant or a service user, it means moving from being a passive actor in this thing called health and decision making to being an active agent. And if you're someone like me from a community organisation or from a VCSO organisation, it's about moving from being an occasional advisor or an occasional service provider with limited power, often, to having a full seat at the table and being an integral part of the health ecosystem. I've got a column on why. I'm going to skip that because I think you discussed that a lot today. And again, Daniel said earlier on that the why has been around for a long time. And my mother, who, Hilna Fontaine, who founded our organisation, has been a social activist for decades, would also say, I'm tired of discussing the why. The why has been established. Can we get off with the doing, please? So that's for you, Mum. So in phase 2, which is kind of 2023 to 25 funding, we've been able to kind of take some of those call to actions from phase 1 forward. And that's really thinking about how do we model prioritising meaningful research across these stakeholders? How do we adequately equip the stakeholders we want to be involved with the skills, behaviours to do this? And that's thinking beyond just institutional researchers. That's what I call people who are within these beautiful buildings, but actually, you know, a researcher that exists across the whole ecosystem. And how do we consider community-partnered or community-led research models, which is targeting minoritized and marginalized communities in particular? So we held some sense-making activities and events and workshops. I know that there's some people in the room who have been there with us. A really, I think, fantastic workshop last November, our research prioritisation workshop. We had 36 attendees, half of which were community organisations, half of which were health system, health research, health professional stakeholders. We discuss things like what's the gap or alignment between what communities consider priority health areas versus what is being funded and delivered within the NHR, within the ICB as an example. But we also did co-design this model for equitable partnership, and it's not probably massively clear, but I think the point is that we talk through in a really simplistic and illustrative way, what is this thing called research, from funding and commissioning through to dissemination and impact evaluation. Where do communities and patients typically get invited into the room, which we felt was in the kind of research delivery, be a participant, please, very important, be part of a PPIE panel, please, okay, great, but how often are we involved in the entire life cycle? And thinking about things like impact, how do we make sure that research outcomes also align with outcomes that matter to communities? But how do you also make sure that the research process is delivered in a way and evaluated and measured in a way that demonstrates safety, inclusion, and the outcomes that might matter to community and patient participants? I'm so out of time. So we piloted some models. We did some things that might help. So we recruited some community partners and we recruited some research teams. And the idea is that we bring them together for some equitable joint decision-making around, for now, in-flight research projects. We had 55 community organisations across South East London apply. We were able to take 8 forward within our funding. And we had 37 research teams across the King's Health Partners, essentially estate, who also signed up to be part of this. And we were able, within our funding, to take 4 forward. So we had people. We then looked at training and capacity building, and our ARC partners and ourselves did some mapping of the training resources that would be available for community organisations in this space. Again, I don't have much time to go into the detail, but essentially there's a big gap between what is available and what we've heard through training requirement workshops that community organisations need. So I know there's lots of good stuff on platforms across this estate, but actually, has that been designed for community organisations with the voice of community organisations? Is it accessible, and does it cover, again, the end-to-end research life cycle? We didn't think the answer was yes, so we built some stuff. So for community groups, we developed the Mabadiliko Academy community-powered research, and that's a digital and workshop-based program where if you are a community organisation or just a member of the public who wants to know what this research thing is, so that when I'm invited into a room, I feel sufficiently capable, confident, and able to use my voice in a way that doesn't make me feel like, well, why am I here? And actually, can I converse with these people who might have the PhDs and all of this experience? So it's not about just bringing people into the room, it's bringing them into the room in a way that they are empowered and capable, and that there's been sufficient investment in them as part of this process, and maybe almost as part of an EDI kind of approach as well. And then for research teams and researchers, we had the Cultural Humility Academy. I think cultural humility has been mentioned a few times today, but this is really about not assuming that this work is easy, and that actually when we bring people into a room together, we need to make sure that communities are safe in those spaces, and that also researchers are confident in their ability to be sensitive and to be humble and to manage what can be quite a different set of power dynamics. If you're typically used to being the lead voice in the room, if you're typically used to involving people and then taking that away and deciding with the degree to which that gets applied, versus actually saying, no, in this room, we are not leaving until we've collectively decided. It's a very different way of working. So are they ready for that way of working and that thinking and feeling confident in doing that? And we brought them together in programme advisory panels where they discussed some of these in-flight research projects. In both phase 1 and phase 2, we evaluated the projects. And our ARC colleagues led on this. There was some kind of good acceptability, feasibility type assessment and evaluation of our models and interventions, but we also brought in these other metrics like trust and capability and commitment and subjective well-being. So again, we're thinking about when we're developing these models, whether they're then models that we're developing with the Dream Team, whether they're the King's model, I guess what we're saying here is that we have to also make sure that we are evaluating the impact of these models on the people that we're inviting into the room, and that might be different from some of the traditional research outcomes or health care outcomes that we might normally think about as well. So what have we learned so far? Lots of really brilliant, motivated people out there in the South East London world, within research institutions and within communities. There was really positive evaluation of these interventions, the capacity building interventions, the workshops that we've been delivering. That doing this isn't easy. And I just want to come back to that again. I think when we have these really great models and initiatives coming out, I think sometimes there's an assumption that because they are the right things to do, they are the easy things to do. But in the moment, working through navigating different perspectives, power balances can be quite tricky, and it needs actually quite sensitive facilitation and a level of expert facilitation for those spaces too. But the impact can be transformational. So there's a couple of quotes from our participants, and I can't quite see them, they're way small on my slide, but people talking about it being really uncomfortable to have some of these conversations, but ultimately leading to kind of really tangible and practical solutions that felt that they could help bridge this gap, moving the from to the to. Community members saying that through our conversation, language barriers are broken down, intergenerational trauma, historical trauma has been addressed. Again, uncomfortable, but that's a good thing. We have to lean into these uncomfortable conversations. I think, again, the speakers talked about calling out structural racism and saying it and dealing with these difficult issues. It's going to be uncomfortable, but that's okay, and we can get there together. We had researchers saying that they understand now that the cultural humility approach means that you cannot fix this in one meeting or in one training session. Actually, these are lifelong self-reflective processes that need to be re-engaged with over and over again. Community organisations saying, okay, I've got a voice and I can use it, and I feel more empowered at the table now that I'm meeting with others. And it's demystifying this huge system thing called research. And that together we're meeting as humans around a single goal around reducing health inequalities. The big challenge, I guess, this is really highlighted by our researchers, is that individual researchers, those individually motivated people, and sometimes we're relying on individual motivated people, and maybe their teams, need much more support at both local and national levels if this is going to be what we'll be discussing today, business as usual, and not a shiny project that happened in the community once that we kind of put on a showcase and then move on from. And so a kind of couple of quotes from our research participants saying that the PAP, our Program Advisory Panel, as delivered in our current phases, and we're evolving this, and this project will run until 2025. It works really well for flatter structure teams and organisations when there aren't lots of organisational constraints, when I can go back to my lab and suggest that we do this as business as usual and there aren't lots of organisational barriers that stop that from happening. And money, saying, well, we want to do this well, but actually our grant applications don't all require or provide for us to do this work. So the money has to follow the intention. So call to action, what next? Mabadiliko, we're really kind of glad to be being able to supply some of this information, this learning from REN with some other projects. So certainly within South East London, we are now the partner with the Health and Determinants Research Collaboration in Lambeth. That's part of the HEART programme. So we're taking some of the models that we developed through REN and applying them for Lambeth HEART. We're also working with the likes of Wellcome around looking at how they capacity build their engaged researchers, so we're kind of a similar kind of idea, and working with the Medical Research Council on their equitable partnership strategy. But what else can we do, I guess, within this system or in this space is the question. If I'm being very transparent, it almost feels like our dream team, you know, Hayley, there's people in the room here who are part of this dream team. We're super motivated to find homes for these models and these tools, but actually finding the right home for that within South East London is feeling quite tricky. So where do we put these tools? Where do we put these models that we're developing? Where does implementation happen? That's a question that maybe I have for someone who's outside of the system, but that's a question that if anybody's got any answers to, then please email me. And my email's on the board, so Nadine, or also a big shout out to Adam Kamenetsky from our team, who's been leading most of this work for us. So you can email Adam as well to get in touch and help us answer these questions. But what could you do? What could we do? How do we make this collectively business as usual? Now that we are developing and evaluating tools that actually might help take this from being a wild ambition to a thing that could actually be done and that we're not discussing in the next 20, 30, 40, 50 years. Thank you.
Thank you. Thank you very much, Nadine. Lots of important thoughts there. What does continuous co-design look like? I think that's a really critical question for us. And I'm going to invite Emily to come up for a few moments. We've got a few questions on the Slido. I'm trying to pick a sufficiently, she said easy. That's like a red rag to a blue. So I've got a question here which says, and thank you for doing this. Inequality in access to healthcare covers a broad spectrum. Can you share an example of inequality in access to healthcare that not enough people know about or are acting upon?
Yeah, it's a good question. And I'm really pleased that today's talks, particularly in this session, but also elsewhere, have particularly focused on ethnic inequalities, because as many of us will know, and Nadine and her mum have been working on for decades, race inequality is something we haven't been addressing, and it is only more recently that leaders are comfortable saying structural racism out loud, and we do need to be recognising and celebrating that. Gender inequalities is something we're much more comfortable with, but and I will never want to diffuse the focus on race equality, because we have so far to go to reach equity, as Sabrina really beautifully illustrated. But I would say that the trans community now is the group perhaps that is struggling most to have their voices heard, to be feeling recognised, necessarily having their health needs understood, but also just their day-to-day lives even be acknowledged and recognised. So I'd say that they're probably our next big group in terms of, well, they're a small group, but with great needs. So they would be, I think, that's going to be a big challenge for the future. But and it does depend what the political landscape looks like for how readily people are allowed to engage with that conversation or encouraged to. But they're a hot topic that we should be thinking about and worrying about their health, I'd say.
And obviously there's great intersectionality in that with the race inequalities for that group as well. And do you think that thinking about gender inequality, race inequality, and inequality in the LGBTQ community, there are things that lessons we haven't learnt from some of the advocacy work that's been done in those other areas, so some of the improvements are synergistic rather than happening in silos or in parallel?
So it certainly is siloed. And in fact, intersectionality wasn't raised as much as is often the case in EDI talks today. It's really tricky to do intersectional research in EDI well. And I think it's something that we're really struggling with across our EDI, all of our EDI work in universities and in healthcare. But it is something that obviously, if we do it, it means that we do it all much better, and we're really working for the people who have multiple identities across marginalised groups. I've forgotten the first part of the question.
It's kind of thinking about, is there something we can learn in any of those particular areas that can bring more of that synergy?
It's a really tricky one. I think certainly around gender equality, we can learn that's become much more comfortable. And so that's, I think, all we can do is just talk about it, but not keep talking about the same things. We've got to be moving on, looking for solutions, but not let these things just sort of fall away, which we have seen, particularly around race equity discussions. You know, in 2020, everybody was up in arms, and suddenly, then if you're in EDI work, you'll be familiar with this sense of, well, we've sort of done that now, haven't we? And we really know we absolutely haven't. So we have to keep the conversation, work with the discomfort, as Nadine points out, get used to the discomfort, and that's how we move on. And I assume that's what happened in gender equality, and that's why we're so much further on. But it is that being comfortable with the discomfort to get to the next stage of fluency and competency.
Thank you. I've got one, I don't know if it's just a tricky question. It kind of builds on that, and it builds on something that Nadine said. Thank you to Nadine's mum. No more why, a bit more action.
Oh, no.
All the presentation so far has been helpful and incredibly informative. However, it seems like an endless uphill climb with no end in sight. What tangible approaches should we be taking back to our teams to support the advancement of EDI in the healthcare system and in our workplaces?
Big questions. Well, I'm an optimist, and I really like the way Saima and you ended it with that, with an optimistic view. We know what we need to be doing. We have a session today, a really serious conference, which is dedicated to addressing health inequality. So this is becoming, to some extent, more business as usual, although the actual implementation of the initiatives that are going to get us to equity, we're not quite there yet. But I was also trying to think through what are the key things that have come out of today. And what I've been surprised by, but really reassured by, was how much people are talking about PPIE, because in other disciplines, PPIE isn't even a thing. In sociology, they don't really talk about it, and yet it's often a human-focused subject. So we are a long way ahead now, and although, again, I think I mentioned, today we've seen the exemplars, and what we need to do is for that to become normalised within our team. So it's about everybody here going back and expecting that sort of quality to be coming out of their team rather than it being a standalone example. And I think the trust building is absolutely crucial. So the hearing the voices, as we heard from Andrea, listening to the two people, but I'm really engaging with people from our community. That has to be our primary target, and it leads to such an improvement in the quality of our research, sort of irrespective of whether we're doing the right moral thing. It actually leads to better research for everybody. So I think that sort of should be our resounding message from today, because we're a lot further on than we ever were. We're in a positive space. Unfortunately, it is a little bit of an uphill struggle, especially in a resource-constrained environment, because some of this does need extra funding. But there are lots of us invested. We need to influence others to sort of share that passion and that enthusiasm and the moral case for it, if we have to. But I think it's a time of positivity and hope. Albeit tricky.
It is very tricky, and I have an old school colleague here, and she can remind me if I was an optimist at school or not. But I feel like I actually have become more optimistic over the years. I'm not quite sure what I've been drinking. I'll find out later. But I do think that actually a part of the answer to that question is actually that it will always be a bit of a climb. So we do have to help each other to know how to have hope. And some of what we've listened to here is really hopeful stuff. It's not just looking at it from the perspective of, oh, well, I'm not doing that in my unit, but actually, how can I take what I've learned and what has been learned here to other areas? And actually, hopefully, that can be a hopeful activity, not just a kind of a deficit model, but something that we can say, if they can do it, we can do it. If someone else has already done it, I can learn from that and build on that rather than having to start from scratch.
If I may just add to that. So Nadine's point about recognising the burden, and I think that is really important for most of us in the room who haven't necessarily all had the lived experience of racism or the health inequalities that others have. And so knowing that we have a responsibility for driving that forward, and noting that it is extremely hard work. We need to be trying to stop people from burnout, but that's not uncommon in EDI spaces. And I think recognising how hard it is hopefully galvanises others to support, especially if they're in a position of power.
Absolutely, I think that's critical. And actually, when 2020 happened and George Floyd died, I remember talking to lots of my family and friends, and so many of us hadn't really reflected on our trauma. We learnt new things about racism in that time. And lots of people thought we already knew it, and we didn't. We were kind of learning as other people were learning as well. And I think that had a kind of a twofold effect. One is to be able to describe a little bit more of some of the trauma and the burden of racism. But actually, sometimes it made us maybe more sensitive to it, because we'd kind of not really, we kind of had a bit of a wall or a bit of some protection, and that brought it out. And so I've, talking to family and friends and my children over the years since that, there has been an increased awareness and everyone's been more aware, but it's also in some ways made me a bit more tired, because I'm a bit more aware all the time than I was before. And so I think that burden that Nadine highlighted is a really critical thing for people to take on board. Thank you very much, Emily. And thank you to everyone. I hope you've had a really great session. My final thing to do while I'm sitting up here, and you've had me for over 90 minutes, hope it's been amazing, is that I am now delighted to bring Professor Graham Lord back up to the stage, our new Executive Director at KHP. Graham has also taken on the role of Senior Vice President, Health and Life Sciences at King's College London, and serves as Chief Academic Officer, a non-executive director role on the Board of Directors at Guy's and St Thomas's and King's College Hospital NHS Foundations Trust, a newly created post unique in the UK. Thank you and welcome back.
Gosh, I feel tired when you read out all of those things in my job title. I wonder how I'll get anything done. And actually, I came this morning thinking, yeah, it is an uphill struggle. You know, we see, all these comments about the NHS is broken, and as we discussed that this morning, actually, I've finished today extraordinarily optimistic because of everything that we've discussed. As you say, we don't need to talk about the why, but I think very much the purpose and the vision of King's Health Partners is actually that we are all partners. We are partners in our community. I think the P of the KHP means our community. And I think that together, if we combine all of our skills, that we can, push the stone up the hill a bit more easily. And I think that's what I really do take away from actually the inspiring comments and all the fantastic work that you've all been doing for 15 years. So I've been here for 3 weeks, and as I said earlier on, the credit will all be for you, but my job is to make it easier for you. As we said, we know what the why is. Let's just get on and do it. So it's a fantastic day, and I just want to say thank you to everyone formally for what you've contributed today. And I think, first of all, our chairs and our speakers, they've done a brilliant job. I think to name just a few, I think what Julia Gillard said this morning was fantastic. And I think it set the tone for the day, and I think we discussed earlier about what are the golden threads, and Sabrina mentioned, I think, equity is a golden thread through everything that we do. And, the question was, what do we take away from this one? We go back to our bits of our organisation, part of the partnership, and actually it's how we live those values, how we, people say, what's culture? Well, culture is what you do when you don't think anyone's looking. And actually, I think, living these values are so important in all the decisions that we make. The people that were in the room, the way that we talk to people, make everyone feel an equal member of the team when they're sort of sat around the table, to the points that Nadine was making. And I think we just need to reflect on that on a daily basis, and it can change the world if we all go back into our individual constituent parts of the partnership and deliver that. I thought what Phil said about King's Health Partners Centre for Translational Medicine was really important, particularly the vital importance of pace and scale. And I think what I will take back is that we just need to get quicker in our back office functions. I think we all know what we want to do, and we make it hard for ourselves. So that's kind of like, if you like, the unsexy bit in the background, but we've got to make our machine work efficiently. And I will take that on myself to ensure that we measure what we're doing. So you guys in the room can just get on and deliver. I think that operational machinery is often, we often underestimate how much it puts people off when you've tried to get something signed off and it's taken you a year and a half. You just give up. People are already working hard enough. Our job in the partnership is to make it easy for you to do your amazing work. I thought Prashant Jha's collaborative work on the menopause app and the product with 3,000 women, and develop a wearable technology that can actually mitigate these life-altering effects of the menopause. It's just one example, but also a scalable model of how we could do this across multiple areas, was just fantastic in the area of personalised health and the digital health space in general. And of course, I think the most important thing to say is sincere thanks to our experts by experience. So Angela and Ronki, I don't know if they're still here, but just let me sort of formally thank you. Actually, from the bottom of my heart, I think you generously shared your experiences with us, and you privileged us with your expertise of chronic pain and sickle cell disease. And as I'm sure many of you know, this month marks Sickle Cell Disease Awareness Month. And I've been sort of leading various bits of organisations around the country for the last 20 years, and particularly bringing people together with different skills. And often you'll have academics that will talk very passionately about their bit of research, and everyone else will be rustling their bags of crisps, and then the clinicians will come in and talk about what they do in their clinical day job, and then the other half of the room rustles their bags of crisps. And the second that you have an expert with experience, a patient or someone from the community get up, you can hear a pin drop. And actually, I think whether we're delivering healthcare, whether we're doing research, what do we mean by research? We've had a lot of talks about that this afternoon. In fact, we need to remind ourselves continuously why we're doing this, and that's about to treat each other as humans, to understand the particular burdens we bring in to the room with us. Sometimes they may be invisible, often they are, and actually do our best for the patient. I think if we organise our health services going forward about the needs of the patients in our communities, I don't think we will go far wrong. I think that's an inalienable fact that I've taken with me throughout my career as a medic and hope to carry forward as the Executive Director of King's Health Partners. I think the days run extraordinarily smoothly. All the technology, it probably collapsed now, but has worked for the first time that I can see. So the Slido worked, the videos worked. So fantastic. Thanks to Autumn Live, who have helped to put this on today, and also the King's Health Partners communications team. Special shout out to Wenda, but also Liv Lurch and Christy Norris. So actually, can we just give a thanks to the team that have catered for us as well? So, as we plan our future at KHP, I think we need to start by looking at the world we live in today. We can't be too non-recognising of the challenges we do face, because I think that's the way, that's the diagnosis of Darcy, right? So Darcy, the diagnosis, get it right before you get to the prescription. So let me just reflect a little bit on what Ara said about his review, because I think it is important to check that we're lined up with it, because I think it was a very good report. I don't think it was particularly surprising. I think he said something similar in 2006 or 2007 when I last discussed it with him. But actually the point is we've not addressed them. That was more than 10, 15 years ago, and they're still the same. So actually, we've not done a great job, actually, as a country, for a variety of reasons. I think one of the things that he did highlight, which was important, that I don't think people had quite realised, we sort of talk about austerity, and Julia talked about it this morning, the comparison between the UK. In fact, Chris Whitty's been talking about it this afternoon about our response to COVID in the NHS. Is that he highlighted a £37 billion capital spending shortfall over the past 15 years. And we wonder why staff in our organisations can't work when there's been no funding for the buildings that we work in. And we know that total factor productivity in economic terms is capital and labour. And actually, you can't have people working efficiently and falling down buildings or parts of the infrastructure. He mentioned that public support for the NHS is fraying, and there's mounting dissatisfaction over waiting times, quality of care and health inequalities, and we've highlighted a lot of that during the day today. There's also been a worrying decline in clinical academics, however they're defined. I define that in the broadest sense. And researchers practicing in the NHS, and actually to bring about innovation and transformation, we're going to need people involved in research. Let's just call it people involved in research rather than clinical academics. Terminology can sometimes be helpful, it can sometimes be unhelpful. But actually, I think we need to be very, very inclusive about what we mean about people doing research, particularly engaging and working with our communities. NHS institutions see life sciences industry partnerships as being important but not urgent. That's from Darcy's report, not my own words. And that they fall down the league of priorities amidst a long series of waiting lists and tight finances. That's understandable, but it's something we need to address. So even though he was formally not asked to write a prescription, Ara couldn't help himself. He did make a few suggestions about where we might do that. I think improvements to operational management are really, really important. So it's a systems re-engineering. Again, that's a bit like the back office for the whole of the NHS. How do we do this better? He suggested that we need to drive through technology-enabled transformation of care pathways at every stage of care. We heard about that this afternoon. But critically, we need to do that in partnership with the patients and the populations we're trying to work with. Otherwise, it just won't work. It's just bad transformation, like, not treating people or patients with the needs that they have. It's just bad medicine. It's just terrible medicine. We didn't come into this to do bad medicine or deliver bad care. So we've got to fix this. And I think we need to grow multidisciplinary teams. We've heard a lot about that today. And available resources in primary and community health settings. I think there was a guy called Charlie Munger, who, for those of you who don't know, that is a guy that basically runs Warren Buffett's portfolio, or did before he died. And he said in 95, show me the incentives and I'll show you the outcomes. And that's very, very true in healthcare as well. If we don't resource these things, they're just not going to happen. We'll still be stuck with the why in 20 years' time. And I don't want to stand up in even 5 years' time to say, why have we not addressed this? So influencing the funders at the very early stage is critical. Otherwise, you won't align your incentives with what you're going to deliver. And it's Management 101 to say nothing will change. So how we do that through policy, intervention, advocacy. I think we heard a lot about the work in King's around the Policy Institute. And I think we really need to push our politicians to change policy frameworks whereby we do deliver the changes that we all know need to be delivered. Without that, we can't do it. And we can do that as a partnership. We have a strong voice. We have a much stronger voice if we all speak as the entire community of South East London, by which I mean our community, our hospitals, our primary care, everybody involved. This is all of us together. Otherwise, it will be an insurmountable problem. I think, a lot has been spoken about system-wide shift from treatment in hospitals towards community-based care aimed at promoting healthy lifestyles, that we heard a fantastic example about this afternoon, and preventing or delaying long-term conditions. Now, we've known about that. Prevention is better than cure, I think, it's about the oldest phrase in the book of medical education and training, but we don't really do it very well. And we've got to simplify and speed up our processes for establishing clinical trials to maintain the competitiveness of the UK life sciences base. Is really important because our trial participant figures are only slightly above the pre-pandemic baseline. Non-commercial clinical trials have more than halved since 2020, and this is a collapse that we need to recover from, because we need to be globally competitive. So that was Ayodele's diagnosis. So what prescriptions are starting to dribble out from the government? I guess we'll find more about it on the 30th of October when we find out about how these incentives align with what they're trying to deliver in the budget. So Keir Starmer's proposed solution is a forthcoming 10-year plan for the NHS, which is expected in January. And that will be framed around 3 systemic shifts that Wes Streeting's also spoken about. So a digital NHS, and that's soundbite of moving from analogue to digital, harnessing technology to improve care journeys and fast-track treatments and give patients more control over their health. Secondly, community-led care, shifting care where possible from hospitals to communities to ease hospital pressure. And thirdly, tackling disease at its source, a bold reorientation of resources from treatment back to prevention. As I said, all things that are relatively obvious, and it's up to us in KHP to figure out the how, the what and the how, and we've got to do that now. So just reflecting very briefly on the global state of health and life sciences, we know that healthcare innovations and technologies have jumped leaps and bounds in the last decade alone. Health and life sciences sort of ideation and incubation of plans is not really an issue anymore. We know how to do that. We're very good at that. Pace and scale of implementing those changes is a global problem. So this is, as I said in the morning session with Julia, no one knows the answer to this. I don't think we should beat ourselves up that we don't know the answer today. Where's the silver bullet? Because nobody knows the answer to this. But again, together we can. We can figure this out. Translation of research into clinical practice is not moving fast enough. And we've really got to accelerate the translation of research into patient care. That's what we're here for. And this will be transformational for the delivery of impact at pace and scale. So what does King's Health Partners actually do? Because actually it's about measuring outputs, equitable outputs. If you put one input in, you don't want one output out. Sometimes it feels like healthcare systems put one input in and get half an output out. It's about how you use it as a force multiplier. So you get one input in, however you define it, and get 5 outputs or 10 outputs. We have to do that. And that's not just about more people or more money. We know that it's not just about money. We have to change the way we do things fundamentally. The burden of health inequalities, as we've heard this afternoon, is at an all-time high. I don't need to give you the statistics. You know them all. What we do know, and this was a paper that came from the ARC and from our Policy Institute, so I'll give it a special call. I don't think she's here today, but Annette Barrett's fantastic paper, recent study published last week, that show that when clinicians, researchers, doctors, nurses, midwives, communities, and healthcare organisations engage in research, healthcare performance improves in a dose-dependent manner. It's quite extraordinary, actually. Beautiful piece of work. I remember discussing actually with Ayodele about 10 years ago about, is there any evidence that academic health sciences make any difference? And there was 1 or 2 papers from Americans say, oh, probably not. It's just because you've got more doctors and more nurses. There's now actually pretty good empirical evidence that this is how you drive up clinical outcomes through research, and research in the broadest sense. And I think, therefore, what we're doing here is the way that you shift outcomes. And we need to make sure that we do that in an equitable manner and that nobody's left behind. So at King's Health Partners, we have a critical role to play in reinforcing the value of important research and education in strengthening our NHS and our care system and improving patient care. And at KHP, we can play a part in solving these problems through our partnerships. And I've realised I haven't moved my slides on. So who are we? We've had lots of talks today. We've heard from experts by experience. We've heard from communities. We've heard from researchers and clinicians. And we bring local communities and local international partners together to encourage collaboration that will pioneer better health for all. That's our strapline. We're not a fifth organisation. Instead, we're a connector. We're a capacity builder. And we're a creator of opportunity and innovation. And we've seen great examples of that today. We need to do more of that. We're here to upskill, to connect and empower our partners to work together to improve patients' lives faster. And we instill in all of our partners that we're stronger together. I mean, we are King's Health Partners and everybody we work with. That's the partnership. It's an inclusive partnership. It's not just about the 3 hospitals and the university. It's all of us. And I think reimagining that partnership and how we work together to deliver is what we've been talking about all of today. And when we move away from here, we need to take that with us into our respective parts of our communities. And KHP colleagues have already achieved a tremendous amount. I think the recently published impact report that you'll have on your tables reflects just a snapshot of the partnership's triumphs, actually, under the work you've all been doing, building on KHP's foundational structure of clinical academic integration and a continued commitment to capacity building and training tomorrow's academic and research leaders. And I guess I'll highlight just a few achievements, which are quite important. We've invested £14 million in partnership with the Guy's and St Thomas's Foundation into cutting-edge translational medicine through our KHP Centre for Translational Medicine that Phil told you about, with the goal of ensuring more people receive the care they need. And you saw from Ronke, the curative treatments. We do have it within our grasp for a large number of diseases to cure them. It's never been possible before. Extraordinary. We've developed new models of chronic pain care that we heard about this morning by working with people with chronic pain through our Mind and Body programme, some of which you heard about today. And as I mentioned, our work with the sickle cell community. Sickle cell disease is the 12th most common cause of death in young children globally. I was talking to David Bean earlier. He wasn't able to stay for this final piece and said, Graham, how do we balance local and global? Sickle cell is a global disease that disproportionately affects our local population. I see no zero-sum game between being the best we can for our local population and addressing global healthcare challenges. Approximately 15,000 people with the condition in the UK in sickle, and 6 to 8 million people worldwide. That's a very big population. King's Health Partners Hepatology provides clinical leadership, as you heard, for sickle cell disease locally. We're part of the South Thames Sickle Cell and Thalassemia Network, and we care for more than 4,000 patients with sickle. And we've got the largest sickle research portfolio in the UK and offer patients the opportunity to participate in clinical trials with new drug treatments, CRISPR therapeutics, gene therapy. These were, a pipe dream. Only sort of 3 or 4 years ago, actually. So that pace of change we need to bring to our patients as quickly as possible. They can't wait. They're suffering with pain. They're dying, and we haven't got any time to wait. And beyond our local work, all of our lead consultants in this space regularly contribute to national guidelines, including the recently published standards for clinical care of adults with sickle. We're proud to work with the community, ensuring that their experiences shape every arm of the work that we do. So, to the future. This is the vision bit, I guess, that they have asked me to talk about. So we are at a turning point, a new government, a new 10-year NHS plan coming, and new leadership at King's Health Partners. We're working closely with our partners to develop our 2030 strategy, and that might seem a long time away, but actually what we decide today and over the next few months will determine the success of that. What's the directionality? What are the key actions we're going to take away? And we're co-producing that with all of you and everyone else across King's Health Partners. We will retain our key priority areas at KHP: personalised health, population health and digital health and data sciences. They're fundamental platforms, but then what do we use them to deliver? Actually, they're enabling platforms, but we need to decide where we prioritise. But we need to do that with a holistic mind and body approach running through all that we do, which perfectly aligns with UK government's 3 priority areas of action for the NHS. KHP's founding mission still stands true today, 15 years on. We want to pioneer better health for all, and this will remain at the heart of any new strategy we put together with you. So looking to the future of KHP over the next 5 years and beyond, we want to reimagine what pioneering better health for all means. A reimagined partnership will involve developing shared strategic objectives across all of our partners and engaged communities, while fostering relationships with new prospective partners around the world. This is a global problem. Maybe some of the answers will come from overseas that we can implement here. We'll use the strategic development process as an opportunity to recalibrate, refocus, and deepen our impact, while keeping our goal of pioneering better health for all at the partnership's heart. We look forward to discussing the strategy with you further and getting your valued input throughout the process, and essentially we've started that today. So to finish, what do we actually mean by pioneering better health for all? Pioneering captures our absolute dedication to leading the way in healthcare discovery and innovation, not only in developing newer treatment technologies, but also in reimagining education, workforce models, and care delivery pathways. We build upon the collective strengths of our partners to drive research breakthroughs, create cutting-edge educational programs, and implement new care models that meet the evolving needs of the communities we serve. And by embracing innovative approaches to research, education, and care delivery, we aim to set new standards that will shape the future of health locally, nationally, and globally. Better health. Better health represents our holistic approach to health and care. We're committed to integrating mind and body across all of our programs, acknowledging how intertwined physical and mental health are. Better health also means understanding the impact of wider social, cultural, and economic factors on health outcomes. And by understanding and working with our partners to address the broader determinants of health, we strive to create a more comprehensive and responsive health and care system that promotes overall well-being, healthy minds, and healthy bodies. For all is our commitment to equity, diversity, and inclusivity. We are dedicated to ensuring that the benefits of innovations and improvements in healthcare reach everyone, regardless of their background, socioeconomic status, or geographical location. Our goal simply is to create a healthcare system that is truly inclusive, where every person can achieve good health, and where disparities in healthcare access and outcomes are systematically addressed and reduced. For all also means greater focus on the pace and scale of clinical research, so more people can receive the best care faster. We all know healthcare systems around the world are under crippling and growing pressure, but we remain optimistic that with our combined expertise across the partnership, we can be bold in our 2030 strategy and actually play an integral role in restoring our NHS and serving communities in need. Thank you to each and every colleague across the partnership for your extraordinary talent, amazing hard work, and fantastic contribution. Thank you very much.